Durga ma'am, next slide, please.
The slides are not visible now. Durga there? Hello?
Ma'am, Durga ma'am.
I think she also lost connectivity. She's just joining.
So today's topic that we are going to discuss or we are going to see in depth is understanding and managing clinical risks. So clinical risks are inevitable, yet their existence cannot be undermined and accepted. The most important aspect about them is
Priyanka, are you there? Hello, Priyanka?
yes, ma'am.
We lost you again in between. Yes.
Am I audible, ma'am?
Yes, you are audible. We're losing time, my dear. Please continue.
Okay. So clinical risks are inevitable, yet their existence cannot be undermined and accepted. The most important aspect about them is not to attempt to avoid them or silence them. If you see healthcare sector, clinical risks are always there. But to deal with them and to come out with effective preventives so that we have best of outcomes is what we are going to understand in depth with this particular chapter. So we have to deal with them in a manner that they lead into developing the most of the sustainable preventive measure so that the outcomes are for a longer time and they give us what we expect out of them. Next slide. So these are the objectives that with which we are gonna go further. First is to create and maintain safe systems of care. So once I know what are the risks, once I know what I'm looking at, what are the threats that are prevalent around me or in my organization, obviously when I start working towards them, obviously when I start eliminating them or reducing their effect, I tend to maintain a safe system of care within the organization. Next is reduce adverse events. As we all know that adverse events are always there. We have seen it, we have lived through it. So when you try to sustain or when you try to create a safe system of care, obviously the adverse events are prevented or they are been catched hold prior even if they occur. So that is the second objective with which we are focusing in this particular chapter. Next is to reduce the medical legal implications. So as we all know that every incident that occur in a healthcare system, if at all it has caused a sentinel event, if at all it has caused an harm to the patient, if at all it has given a patient a very bad outcome, that patient has been admitted for one particular reason and now because of the this particular incident, patient is now again into the hospital for prolonged period of time, obviously it calls for a medical legal aspect to it. So reduce medical legal incidents. Last is to improve human performance, reporting system and response method. So if I study my risks, if I know my risk, if I start building on it, so once I have built up, I need to integrate that to the people who are going to perform at the ground level. This is going to give me an improved human performance. This is going to give me a system or a process which is integrated within them. I cannot have an understanding of like patient safety is of prime importance until unless the people working force do not have that same understanding. So I need to give them that. Once I give them that, obviously their performance will be improved. Whatever the objectives, I will be achieving them and report. Reporting system is we all know how the reports are being reported. We all know how the incidents have been escalated. It is always with consideration. But what I think is always the reporting should not have any specific consideration. It has to be the way it has occurred. So reporting system needs to be improved. We have to report or we have to raise the incidents not with a thought that what can be the negative outcome about it, but we have to focus on what positive outcome I can bring, and with this positive outcomes, how I can prevent this particular incidents because of this particular risk again in the future. And next is the response method. Obviously, if the reportings are pure, the response is also very effective. Next slide. So let us see quickly what this particular video has to tell us.
Is there a video here, Priyanka? It's not playing.
Yes, ma'am, it is a video.
Just seems to be an image.
All right, moving further, we will just go this particular video. If at all I have to tell you in gist, it was all about how the small risks that are there. Sometimes we tend to neglect them. Sometimes we tend to avoid them. Sometimes we even don't even are aware about like this particular risks are around us, which can give rise to an incidences which can give us very bad outcomes, which can give you a very complicated outcome. So this particular video was all about telling us or making us aware how we are supposed to be aware. Now, when you will be aware, when there is a proper assessment, when you will be aware, when you are made known that of that particular risk around you, when you will be aware, when you know that you know this particular risk or this particular area or this particular threat is prevalent in my organization. So how am I going to manage this clinical risk? So there are four-step process to manage the clinical risk. First one is to identify the risk. Ma'am, if you can go ahead. Identifying the risk. I cannot see the tip of an iceberg and then decide, yes, this is the problem and start working on it. Every time I have to deep dive. Every time I have to go to the base. Every time I have to understand the risk. If I'm seeing one incidence, for example, a fall, I cannot just see, yes, patient has fallen, but I have to think, I have to go behind it, I have to go under it, I have to know it from all the sides why patient fell down. This is what is identifying the risk. Whether it was a slippery floor, whether it was improper fitting uniform, whether it was not proper lighting in the patient's cubicle, whether the side rails were down. So identifying the risk is the first prime step of managing the risk. Until and unless I do not identify the risk correctly, whatever rest of the things that has been followed and I'm doing stands null specific. So this is the first important step, that is identifying the risk. Next is reduce or eliminate the risk. I'll be able to reduce and eliminate the risk only when I work upon it effectively. I won't be able to do anything about that threat until and unless I have not studied it properly, until and unless I have not understood it properly. So first I need to understand it. First I need to study it. I need to know what it can give me. I need to know what implications it can have. I need to know what complications it can lead me to, and that's how I'll be able to build an effective preventive measure, an effective effective I would say a structure, a system, a process which will help me to reduce its complications. Third is assess the frequency and the severity. So if I see as a quality coordinator, if at all I'm handling quality, I'm seeing one particular incidence in every month. So for example, if at all I'm seeing fall in every month from January, we are standing today in July. So January, February, March, April, May, June, July. In all the months I'm having fall. So I should take a pause. I should think why my patients are falling. And I need to assess in each fall, during each fall, what was the threat? What caused the patient fell down? So in January, if at all I see that patient has not abided to the protocol that was instructed to the patient, second time it was the side rails, third time it was the improper uniform. Fourth, again the patient is not abiding with the protocols. Fifth, again the patient is not abiding with the protocols. Sixth, again the side rails were down. So I am assessing the frequency of every threat. And once I know that this particular area is again and again getting highlighted, now I need to work on that area. So if at all patients are not abiding with the instructions given to them, I need to strengthen my patient rounds. I need to strengthen the nursing, reinforcing those informations or instructions to the patient as well as relatives. I need to make sure that the relatives are there with the patient. I need to make sure that my RNs are taking hourly round, especially for the vulnerable patient, especially for the patients who are not abiding with the protocols of the hospital. So assessing the frequency, and if first fall was because of side rails were down, patient fell down, no injury. Second fall, side rails were down, a patient fell down, and there is an injury. Third time, it has given patient a fracture, so the severity is increasing. I need to be alarmed. I need to now think that no, side rails or implicating the importance of side rails, integrating the importance of side rails for the patient safety needs to be incorporated within RNs. So this is how assessing the frequency and severity will give me an opportunity to develop better processes. Processes are there, SOPs are there, protocols are there, systems are there, everything is there. But still, if at all it is giving me incidences, still if at all it is not eliminating my risk, still if at all I'm getting the patient's fall, it is not acceptable. Somewhere down the lane I need to rethink, somewhere down the lane I need to redo my processes. So this is how, if at all I identify the risk, if at all I assess the frequency, I study every incident, I study every threat, I will be able to eliminate or reduce the risk complications. And last is assess the cost saved. If at all patient, for example, I have to give you, once the patient pulled out NJ tube, patient was dependent on NJ tube. Now, obviously, if at all patient is dependent on NJ tube, the reinsertion is demanded. So when a reinsertion is demanded, I have to redo the procedure. The manpower is utilized, the material is utilized, the money is incurred. So everything is again a redo. It is again like patient has to go through all the phases. Patient has to be kept NBM, patient has to go to the procedure room, patient has to go through that physical trauma of getting the NJ inserted. So I have to analyze that behind every incident, behind every threat, there is a cost that has been demanded. So once I start eliminating the risk, I will start preventing the incidences. Once I start preventing the incidences, obviously my cost to company and cost to patient is reduced. So this is how I need to now understand how important it is for me to study these risks. Because until and unless I do not know the risk around me, I do not understand them, whatever systems I build on is of no good use. So with these four steps, now once I know what I'm looking at, once I know what it can give me, I'll be able to bring the preventive measures, build on it, give it to the working force, and eliminate the risk. So this is how we are going to understand our clinical risk, and this is how we are going to manage them. Next slide, please. So even if I understand the risk, even if I'm getting the incidences, what I'm going to do about it? What I'm gonna, how am I going to handle it? If at all I am on the admin level, if at all I am on the senior level, if at all I'm seeing that yes, there is one incident that has happened, this was the risk, this was the incident, this was the outcome, what I'm doing about it. So let us see what exactly we are supposed to do. Now, first and foremost is, if at all there is an incident that is happening, firstly, what is demanded is reporting it. Now, if you talk about effectively looking at an incident, and if you are expecting an outcome out of it, it needs to be handled with severity, it needs to be handled aggressively, it needs to be handled in depth. So this particular process starts by reporting the incidents very crucially. I cannot have many thoughts into it. I cannot have many consideration while reporting the incidents. So incidents reporting is basically a formal documentation. As we all know what incidents reporting is, every organization does it. True, that is. But how are we doing the further part, or how well or how in depth we are doing the further, how deep diving are we doing with the incidences is what we are going to understand more. So incidence reporting is a formal documentation when incidents needs to be addressed the way they occur. If at all I know that patient has fallen down, I need to know how the patient has fallen down. What was the sequence of event? What exactly happened after what needs to be reported in depth. For example, if at all I have to ask you all, if you go on rounds and you see that patient, when you're talking to a patient is 85-year-old, case of CLD, and now has been admitted for body ache and vomiting, and you are meeting this patient, and patient verbalizes that I had fallen down at 2:30 a.m. in the night. So how this particular incident will be reported? I want crowd to people to reply on this question. Anybody? Sorry. How this particular incident needs to be reported, that you are meeting a patient and patient says that I have fallen down last night at 2:30 a.m. How this particular incident needs to be reported? Anyone? Am I audible?
Yes,
Audible.
Priyanka. Yes, yes.
So if at all, when you go on rounds, most of the times when we go on rounds, we meet the patients, we ask for their health, when we say that, how they are doing in the hospital. And sometimes patient verbalizes that this had happened, that had happened. And suddenly patient says that, I had a fall last night. So when we tell our juniors, when we tell the managers, or when we ourselves sometimes start documenting this particular incident, what do we write? We write patient had a fall at 2:30 a.m. Am I right or am I wrong? This would be the first statement in the reporting that Mr. So and so, 85-year-old female, known case of CLD, admitted for body ache and vomiting, had a fall last night at 2:30 a.m. Is this the right reporting that I am doing?
May be reported as unwitnessed to fall.
May be reported as unwitnessed to fall. Very good. Any other views? Just like if you have to write, the sequence of events can be later, but what I'm trying to focus here is, or what I'm trying to bring into light is, the concept of us while reporting the incidences needs to be clear. The events can be different, the way the patient has fallen can be different, but the first thing that most of the time the reporting goes is like, the patient, if I have to report, I will write it as patient had a fall. But what I have to stop back and think is, did I witness it? Was there at the time when patient fall, or was there events that were witnessed by someone else? So when I am reporting, when I am writing, obviously I will write that patient claimed of fallen down at 2:30 a.m. So this particular understanding cannot be only with me. It cannot be only with the senior people. It needs to be integrated down. So if at all, I have to ask the nurses, the bedside nurses, my friends who are there in this particular session, if you go to the patient bedside for administering medications, and if you see that patient is lying down supine in supine position, after settling the patient, you have to, now manager tells you to report it. How are you going to report it? Any bedside nurse, any novice nurse here, can you please reply?
We'll call the consultant.
Okay, we'll call the consultant. The reporting is been done. The patient is made comfortable. We do all the assessments required. But when it comes to reporting, again, you have to mention that patient was found lying down because you have again not witnessed the fall. Are you getting me? So when you talk about medical legal implications, all these things matters. All these things are taken into consideration. Tomorrow I'll be asked that you have written that patient fallen down. Have you witnessed it? No, I have not witnessed it. That's the reason it is said it's a formal documentation with medical legal implications. Patients, when in the hospital, are our responsibility. So when they are our responsibility, we are accountable for everything that happens to the patient within the hospital. So when I am reporting, when I am doing the formal documentation, I need to be very, very, very careful about it. So incidents reporting, first thing is formal documentation है उसके पीछे we have medical legal implication back in the mind, and when I'm reporting I need to be very, very, very clear. I cannot mince my words. So documentation where incidences, you have to report it as the way they have occurred. Second step is effective RCA. We all know RCA stands for root cause analysis. When we say root cause, I have already mentioned I cannot just see the tip of the iceberg and understand the problem. I cannot do that. I have to deep dive. I have to go to the base. I have to understand the particular problem in all the aspects. It is not a single individual focused, it is system focused. So when you are doing root cause analysis, you have to bring in all the reasons why this particular incident has happened, why this particular risk was still prevailing, giving me this outcome. There, if I'm on rounds, if I'm seeing that, on one particular floor, I found after mopping, the floor was wet. So when I am walking, I tend to slip. Again, on second floor, I go, again, I have found that, after mopping, the floor is wet. I am picking on it. I am now thinking why the floors are wet. And if at all I can slip, obviously my vulnerable patients will definitely slip. So RCA is focusing on gathering all the information that led to an incident. So taking back again the incidence of fall. If at all patient falls down, first thing that comes on, who was the staff on duty? Why did patient fall down? What you were doing when patient fell down? Where were you when patient fell down? It cannot be only individual focused. It has to be like, when the patient fell down, were the side rails up? Was the patient identified as vulnerable? Was the fall preventive measures explained to them? Was the relative next to the patient? Was the call bell given to the patient? If these things are done, now we go to the environment. Was there a proper lighting in the patient's cubicle? First of all, why patient came down? If at all he had eliminatory needs, why the assistance was not given? And if at all assistance was told, why it was not given on time? If at all patient has slipped down, then why the floors are wet? So when I start thinking in deep, when I widen my horizon regarding the incident, I come to know that yes, this was the problem. Slippery floor was the problem. Patient came out between the gap of sidles and foot end. This is the problem. So when I pick up different areas and now sit to work on it, I will definitely ensure that the preventives that will come or the changes of the processes that will be done will be giving me a sustainable outcomes. So RCA is you focus on gathering all the information from all the aspects and then you analyze them. Now, it cannot be a one-man show. I am looking at the incidents, I'm studying it. It cannot be I. It has to be always we. So now I sit down and I discuss with rest of the team members. I will also include all the interdisciplinary members. Let us sit down, let us discuss why this particular thing was prevailing then, which has given this incident to us. So discussing, and obviously when I'm analyzing the gaps, I need to analyze them on a periodic basis. I cannot be doing it only for one time. I have to do it continuously. I cannot say ki one risk has come, it has given me an incident, I have worked on it and it is gone. It is not like that. It can come back with different phase, giving me a much complicated incidents. So this is what RCA focuses on. It focuses on identifying system failures. So when an incident reporting is done, when you're understanding the risk, when you're treating it, when you're working on it, it needs to be told, the message needs to go clear to the people that it is not individual based. It is not to focus on an individual. One person cannot fail. It has to be a system failure. So when you give this message clear to the people, obviously your incidents reporting will increase. Obviously, people will start identifying the risk around it. People will take it positively and you will be able to identify the risk more and more and start working on it, thus promoting patient safety. The last step is preventive action. So I have identified, I have done my gap analysis, I know where the gaps are, I know where the system failed, but if I don't do anything about it, it is of no good use. So now preventive actions is, as I've told, it always brings new initiative. This is the most beautiful part of understanding the risk and managing them. The most beautiful part and most important, that every incident gives you an opportunity. It gives you an opportunity to build a new initiative, to bring in the new initiative. And this initiative is been incorporated into the working force, into our RNs. So when they start, working on it, implying it or applying it, that is when we see the outcome. That is when we see that the risk is getting reduced, the risk is getting eliminated, and when it is sustained, obviously you have achieved it. It has been done. So preventive action is bringing on the new initiatives. It gives you an opportunity to update your process. As we all know that healthcare will have maximum risk because the person who is receiving the care is human, but along with that, the person who is giving the care is also human. And human tends to do errors. But when you update the processes, when you bring the new initiatives, the dissemination is more important. We need to now focus on disseminating this particular information, these new initiatives, these new updates into our working force. They need to be on the same platform of understanding what we have. If I think that fall is non-tolerant, they need to understand the seriousness of it. How is that possible until and unless I don't disseminate my thoughts, until and unless I don't disseminate what I feel, until and unless I don't disseminate my seriousness into them. So this is how managing the risk plays a very important role. Understanding the gaps plays a very important role. I'm pretty sure all the eminent leaders present here, all the senior faculty present over here, we all are doing this day in, day out. We are handling this. We are living through this. But still, if at all, again, next month I have a fall, it raises a question. It allows us to think. It tells us silently, take a pause, look back, and see what exactly is the missed point. So again, to sum up, while working on it, while doing the homework on it, we need to do the background study. We need to go into it. We need to deep. Next slide, please. Next, we come to complaints and its role and its importance. So complaints in itself is a very negative word. Let us not take it as complaints, but we will take it as feedbacks. Do you all love feedbacks? Do you all look forward it? Ma'am, am I audible?
Yes, Priyanka.
All right. So how many of y'all actually look forward towards the feedbacks or take it positively or look at it? You look forward for having feedbacks. We all do feedback analysis. We all come across the feedbacks. Obviously, when we go on our rounds, when we go to the patient bedside, every time we'll get feedbacks. May it be good feedback, may it be thought of good feedback, may it be very good feedback or very negative feedback. But feedback is always there. But if at all you look at this particular aspect, that is feedback, it again gives you a platform to ponder on what we are actually doing, on what actually things are been happening. So if at all I claim that yes, we are the best, we are giving the best services, but if at all feedbacks are coming in a very opposite direction, so I need to ponder whether are we actually doing the things that they are supposed to be in a manner that they are supposed to be. So complaints and concerns from the patient bedside needs to be taken very, very, very seriously. For example, I had a patient when I was there as a RN in near bedside. So my patient had undergone inguinal hernioplasty, and patient was continuously complaining of pain. So as a student nurse, obviously being truthful, we all have thought about it. अरे यार कितना complain कर रहा है. I am pretty sure we all must have at least once thought about it, like or had this particular thought कि patient बहुत complain कर रहा है यार. But then again, go back, escalate, talk to the consultant. Then consultant will say, ki, like, okay, fine, give a painkiller. I came back, I gave a painkiller. Again, after some time, patient was all okay. Patient was, yes, at discomfort, but still didn't had pain. So I was like, finally. But then again, a call bell, again I went in, and then patient like, sister is paining and it is paining more this time. And then slowly the request is starting becoming an argument, or like the tone gets rude. Then the relatives starts getting a bit frustrated. So then you start getting that vibes that somewhere down the line the things are going out of hand now. And then again I came out, again I told the on duty doctor, again he spoke to the consultant, again he told me what is to be given. I went and I gave the medicine. In the evening, when consultant came on rounds, the patient verbalizes that I had having severe pain. So when the palpitation of women, that is the time he came to know that his umbilical area was quite distended. Patient was having urinary retention. This could have been assessed at the first time when patient verbalized of pain in the abdomen. So if at that time this particular feedback, this particular complaint would have been taken very seriously, or in sound with the clinical aspect of what patient is in right now, the post-operative state, patient has undergone inguinal hernioplasty, obviously patient would have been managed in a much better way. Patient would not have to have or live in that pain all throughout the day till the consultant come, palpate his bladder and tell me that patient is in urinary retention. So the point to focus here is the complaints or the feedbacks are not always to put someone down. It is to tell you that silently somewhere there is a miss and we need to catch it. The moment the feedback starts increasing, the moment the feedbacks on the same aspect starts coming in, or the moment the feedbacks are like in varied spectrum, we need to take a pause. We need to sit down and think about where exactly are the processes failing, or where exactly the gaps are prevailing. So this particular aspect of feedbacks needs to be again taken very crucially. Next is coronial investigations. So coronial investigation, most of the country has adapted to this particular aspect. That is, coronial investigations provides you with the facts. It tells you what exactly had happened and where exactly the healthcare in all have failed. The organization in all have failed. So if at all, I am getting an incidences of patients, wrong patient with sent to OT, patient identification is a miss. Or if you see, the most famous is high alert policy implementation. I'm pretty sure we all follow that high alerts are need to be countersigned. We all know how effectively the implementation happens. We all know what are the flaws. But this particular slide is raising a question, are we normalizing what is not normal? The question needs to be asked is, are we accepting what is not to be accepted? So in the rounds, if I go, I see patient staff has already administered high alert and there is no countersign. Am I accepting it? Am I accepting the reasons behind it? Because if I start accepting or if I start normalizing what is not normal, obviously the feedbacks will be coming. The systems will keep on failing. So the crux of this particular slide is, please take the feedbacks very, very seriously and let us start working on it. Let us build on the system and and strengthen them rather than accepting what has been given to us. Next slide, please. This is another aspect, that is fitness to practice. If you have an employees working under you, if you want the processes to be applied properly, if you want the staffs to do what is been expected out of them, if you want that all the SOPs needs to be incorporated effectively, you need to know how fit they are, first of all, to practice or to implement that. If I bring on the super ended protocols, if I bring on the high ended preventive measures and I give to the staffs and I tell them start implementing, it will not give me anything. I will not achieve anything until and unless I evaluate how fit my staff is, how effective my staff is, and if at all I'm giving it to them, I'm giving the preventive measures them, how effectively they will implement it. Because they are my hands, they are my eyes, they are the people who are doing the job. So I need to evaluate how fit they are to practice. So these are the various areas who tells me or who assures that yes, this particular employee is fit to do what is expected out of them. First is credentialing. We all know how important credentialing is. So if at all I'm hiring an RN as a bedside staff, I will make sure her credentials are good enough to give her that privileging of be a nurse at bedside. Because I'll be handling my life patients in her hands, she will be handling a life in her hand. So how good or credentially equipped she is to do her job. Next is accreditation. It gives you a platform to set the standards. It gives you a platform to create your processes. So again, the staffs who are working, the employees who are working, they have to just abide with those policies and protocols. Third is registration. Registration ensures that whichever staff is getting registered, whichever employee is getting registered, are credentially equipped and they are fit to do the work that they are going for. And last but not the least is personal accountability. I would like to focus more on this. Every person who works, who has a job, will work with responsibilities. They have many different responsibilities with which they work. For example, I have a mobile, I have an iPhone. So if at all it is with me, I will handle it with responsibility. And if anything happens to it, I am accountable to it. If I give that phone to my friend and tell her that please handle this, she, knowing that it is an iPhone, she will handle it with responsibility. But can I hold her accountable if at all anything happens to it? I cannot. So personal accountability is more important. When I am giving a medicine to a patient, I am responsible to give it on time. But am I giving a right medicine at a right time to a right patient? That is my accountability. So when I am well equipped, when I am credentially equipped, when I know my job, when I know what is expected out of me, when I know how it is to be done, I am, yes, accountable to it. So this particular concept needs to be focused in today's era. We need to strengthen this particular concept in our organizations. We need to evaluate our staff. We need to study them. We need to see what are their skills. Are we actually practicing skill mix? Are we actually practicing the privileging? Are we privileging them as per their credentials, as per their skills acquired, how smart they are? Because if at all these all things are failing, all the things that we have just discussed will not be effective. It will not, I will not achieve anything. It will not give me any outcome. So let us now start going backwards. I need to first see how my working forces, how good they are, how strong they are, and then start giving them or disseminating whatever is to be given to them and see the implementation. They will definitely do it beautifully in the capacity that they can. Next slide, please. So let us see the role of fatigue. And fitness to practice. So obviously, every employee who is working will have a particular aspect to deal with. And we need to correlate whether the fatigue that they are experiencing is actually directly or indirectly affecting their fitness to practice. Stress and mental problem is the first aspect. We, being the healthcare workers, we all know what stress is. We all have been through it. We have lived through it. So, if at all a person, if the worker or that employee is under stress, will they be able to perform? Obviously no. Are they fit to practice? Obviously no. So evaluating this particular aspect is very important, is very vital. Second is work environment and organization. How good is my work environment? How friendly is my work environment? How acceptive is my work environment? How good it is to adapt it? Am I being involved? Am I being welcomed? Am I, sorry? Am I being involved? Am I being accepted? Is most important feeling that anybody can have. So if anybody joins the organization newly, how warmly they have been welcomed. Are we giving them time to adjust? Are we giving them time to understand us? Are we giving time to understand the organization? Are we giving that space so as to explore the organization, to adapt to the organization, to the newer area? So if all these things are not happening, they will find somewhere restricted. They will find fatigue. They will find it very much loaded to work in such environment. Third is instruction and supervision. We all have needed it. We all have given it. We all required instructions and supervision, and we still need it. And we have also given it to our juniors. So we know, we understand the importance of it. If at all I am not getting instructions properly, if someone comes, my senior comes and tells me, do this, will I be able to do it? Until unless I'm not been instructed how it is to be done, what it is expected, these are the steps you are supposed to follow, this is the way it is to be done. So do this first, then you do that first. Until unless these instructions are not given, obviously I will not be able to perform. And if I'm not performing, it is building on that stress in me. And if at all it is building on that stress on me, my performance is hindered. So it is all correlated. It is directly proportional. It is directly correlated to my performance, to my fitness to perform. Last is communication issues. We all know this particular aspect is long prevailing. If at all communication is not happening properly, it is not only the patient communication, but communicating with the colleagues, communicating with the seniors, communicating with juniors, communicating with patients, with the consultants. If at all every area is compromised, then somewhere down the lane, the person will start feeling very much low. So we need to explore these areas. We need to understand these areas for them. So as to once we start eliminating all these reasons, obviously they will have more widened horizon to perform. They will have more better way to perform. They will have lesser stress and the performance will be much more appreciated. Next slide, please. So summing it up together, how are we going to manage the risks? First is we need to know how to report. We have seen it in detail. We need to know how a incident, how the risk, how the threat needs to report. And once it is done seriously, how do we respond? Your response matters the most. If with that serious, we have telling we are during CNEs, during the we tell our juniors that we tell the RNs that you need to report, you need to tell us what is happening, you need to tell us what has happened, you need to do this, you need to do that. And once they start doing it, if we show lax attitude, if we show okay fine attitude, obviously their morale will be down, and then it brings us back to the square one. So how you respond, you need to respond appropriately. If the report is coming to your desk with seriousness, you have to respond with that severity. And it's not only the respond needs to be appropriate, it needs to be effective as well. I cannot say just okay fine, I will look into it and then do nothing about it. I need to do something very effectively. Next is discuss the risk management. As I have already told, I have already mentioned that every risk needs to be handled. It needs to be discussed with different departments involved. It is not a one-man show. I myself alone cannot do that. I will only think from a nursing aspect, but I need to have purchase aspect. For example, if at all I have to give you, we had a fall because of the slippery floor, for example. So I just can't tell nurses to, like, make sure that the side rails are up, make sure that the patient, that is all general preventive measures. I need to focus on the slippery floor, because that is what has caused the patient to fall. So now I require housekeeping to, get inputs from them, how we can avoid slippery falls, how we can avoid the slipperiness. I need to have purchase department, I need to have maintenance department. What else we can do to avoid that slippery concept to prevent falls? So if at all I can introduce anti-skid mats, I can, incorporate the anti-skid mats, and then make sure now the nurses explain about anti-skid mats to the relatives and to the patient that this is for your safety. These mats are for your safety. So when you are coming out of the bathroom, make sure you wait on that mats for some time. You make sure that you have the grip. And once you are confident that you have a grip, then you start walking. I cannot, just because I have a slippery floors, I cannot restrict the patient to bedside. I cannot tell the patient not to mobilize. If he wants to mobilize, he will mobilize. But I need to work on my gray area. So discuss the risk management. Next is ask for help. Most of the time, we are very much, taking a foot back when it comes to asking for help. So asking for help is again very important. You need to know what to ask for. You need to know what to ask for. You need to know whom to ask for and at what time. It is very important. So when you start asking for help, it is like it might be a new insight, it might be a new policy to be developed, it might be a new initiative that needs to be done. You need help from different departments. Ask for it. Once you ask for it, obviously you will get it. And once you get it, because patient safety is not only my concern, patient safety is not only nursing concern, patient safety is not only one discipline's concern, it is entire organization concern. So that is the reason you have, and you should, I would say, bring in different disciplines and understand and manage the risk holistically. Next is health records. This is particularly for the employees who are working, for the people who are working under you, to practice fitness, to practice concept. So this is how effectively managing clinical risk needs to be done. Next is, last is the, ma'am, next slide, please. This was again a video. This particular video summarizes of whatever we have just dealt with. So there are basically 4 steps. How are we gonna deal with the clinical risk and manage them effectively? The only line that I would like to say is your risk assessment needs to be effective to give you an effective outcomes. Until unless your assessment is not effective, the rest of the things falls flat. So first and foremost, again, if you recollect the steps of the process, you need to identify the risk, you need to analyze, and you need to see the pattern. Then you need to eliminate the risk. And fourth is you have to take into consideration the cost involved and every other thing that are involved while dealing with them. So this is how we can effectively curb. This is how we can holistically curb the risks that are prevalent, the threats that are prevalent, and come out with measures, come out with preventives, and make sure that the IPSG goal of patient safety is always given a prime importance. Our patients are safe in our care. We should be very much confident. We should be very much feeling proud when we say that, yes, in my care, my patient is safe. How am I going to do it? This is how we're going to do it. I'm going to understand what my organization is. I know what my threats are. I know how I'm dealing with them. I know my preventives are in place. I know I have disseminated them in a right manner. I know my working force have implemented them in a right manner. And thus I know my patients are safe. So tomorrow pops in a question, how you can say nursing is best? This is how I am gonna say that yes, nursing is best because they are promoting and they are sustaining patient safety in my organization. So I would like to conclude here with my topic of understanding and managing clinical risk. And now I would like if there are any questions, if at all there are any areas which I would like to deal more about. So kindly let me know.
Durga, stop sharing. Now it is open to the group here if you have any concern and if you have any inputs into this topic of understanding and managing clinical risk, please feel free. We have another 5-6 minutes that we can spend. Durga, maybe you can stop sharing, please.
Sure, ma'am.
Yeah, please go ahead. If anyone has anything to share or ask Priyanka any question, please go ahead and we have a lot of nurse leaders here. Like to hear from them.
People have raised hand. Priyanka,
There is one person rotating. Do you have a question? Hello? They need to speak up if you have a question.
Roitilin, ma'am, you can ask, ma'am.
Maybe that was by mistake.
Okay.
Okay, any of any nurse leaders here, do you have anything to share? Add to what Priyanka had discussed.
Ma'am, Lata here.
Good afternoon, ma'am.
Good afternoon. It was a very eye-opening session. Thank you for that, Priyanka. I'm sure that the people who is listening to you would have thought, yes, we can do much better way. But what I just wanted to tell, we should remove the fear factor, and we should start reporting all the errors. Then only this will be helpful for everyone to give a quality care. So the input what you have given have to be taken by every nurse in a right manner and never put anything under the carpet. And as well as the nurse leaders or nurse managers, when they are on rounds, should have a very open eye to see errors and do not point out to the people, to the staff nurses. No blame game. As you well said, we may have to do a RCA with an open mind. That's all I just wanted to share to the group.
Thank you, ma'am. Thank you for your inputs. Yes, definitely the fear factor needs to be removed, and it will be removed very effectively once we start accepting it positively. So the moment we go with an aggression to a bedside nurse, obviously half of the battle is lost there. So if we just go with an understanding that yes, we are here to understand exactly what has happened, they will come out in a much different way, and the reporting will also increase. Yes, ma'am, I agree to this, and thank you for your valuable inputs, ma'am.
Thank you.
hi Priyanka, Durga here.
Good
It's
afternoon,
an
ma'am.
extremely wonderful presentation. I really appreciate your emphasis on the documentation part, especially for an unwitnessed fall. It's a very important thing which all nurses need to focus on. And I would also say that most of the time, whenever an error occurs, the tendency is like calling the nurse, who's the nurse involved, and all those stuff. But I think we need to focus on the errors, considering that errors belong to the system and the system belongs to the management. We need to focus on the processes, right, instead of the individual. So very well presented. Good one, Priyanka.
Ma'am, thank you so much.
Do we have anyone else wanting to share anything? Otherwise, we can close this up. And Priyanka, thank you very much for Great presentation, and apologies for the delay, and apologies that the videos could not be played. And yes, you can contact Priyanka, and maybe she can share the link to the video. Sonam, you have anything to share? You're on the video. You need to unmute, Sonam.
Hello, good afternoon to all. This is Sonam Zwika, nurse educator from Fortis Vashi. Yeah, I just wanted to share it was a wonderful presentation here, and I just wanted to highlight that whenever any incident is happening, like fall, so as a nurse leader, as a nurse supervisors, we need to ask how it has happened, not who has done, who is it. Instead of asking that, our things should be like how it has happened. So it will reduce the fear of the nurse, assigned nurse, and it will be a good if we focus on that also. Yeah, thank you.
Thank you so much, Sonam. And it was really good input that instead of asking who, it is better to ask how.
Yes.
That would be my next catchy line for my sessions to the to my RNs. That instead of I will be asking how instead of who. So thank you so much for your input.
Thank you so much for the presentation. It was very, very well presented.
Thank you, Sonam. We have Ajinder Johal hand is up. Do you have something to share, Ajinder? Ajinder, do you have a question or anything to share? So looks like we lost few minutes, but we are just about 12:08. So before we say bye, just wanted to.
Tankam. Hi, Tankam. This is Clara. Sorry, I'm not able to come on screen. I'm outside. So I would like to thank you, first of all, for having set this ground for the entire nurses across India. I think ANEI is in the right track. I'm sure these all will harvest outcomes in the future. That is what I could say for ANEI and this particular program. Priyanka, wonderful presentation. I'm so proud that you were able to convey the right message across to the team. And one point I would like to include here for people to think about is, we nursing leaders, how do we treat people when we are put under stress? There is a star doctor who says the mistake has happened. There is a management who says mistake has happened. Throw this nurse out. This is what not right. So how do we react? How do we behave? And what is a balance that we set? Everybody does mistakes. Doctors do mistakes. Senior people do mistake. But when it comes to nurses, mistakes are taken in a different angle in the organizations. I'm not talking about my organization. I'm talking about in general. So this has become a routine practice. And so I'm very happy that one person came forward to say we have to shift our mind from who has done the mistake to what has happened. The first thing is the correction. Correction is very important when it comes to safety. So anything that has happened to patient, first thing is the correction so that the patient doesn't fall into next level of risk. Second thing is how it has happened and the rest of the investigation can go on. So correction is the first thing. Keep the staff away. Never start on the start of the duty, never advise or do an inquiry or in the middle of the duty, because the nurse's mind will get disturbed, and instead of committing one error and leaving her free, we will allow her to do multiple errors. So never do that. And also when she is going from work, going to rest after night duty, never disturb people, because it is important to collect more information. We can still wait. So the mindset that we have as leaders for approaching towards error is very, very important. First thing, we have to have a confidence that nurse wouldn't have done a mistake, but there is a reason why that she has been pushed to do that mistake. Even if I am there as a leader in that position, I would have committed error. So this has to be in the mind of middle level leaders, immediate reporting authorities, and the top management. Thank you, Tankam.
Thank you.
Thank you,
very
Priyanka.
much.
You did a fantastic job. Thank you.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Jyoti. Thank you very much. So, as a final word and saying thank you to Priyanka, the final word is let's not blame, name, and shame when an error happens. So, let's start asking what happened and what can be done to prevent this from happening next time. And I think Dr. Jyoti brought out a very, very important message is that when you want to investigate on the whatever event that has happened, unless it is a life and death situation, do not disturb them during duty time and do not disturb them just before starting the duty, and do not ask them to stay back after night shift. Do not call them from hostel to do investigation. These are things that I have seen in my own experience. So we should stop this. So that we had done one topic earlier on human factors. Maybe it is worthwhile to go and read up the human factors, how that plays a great role when errors happen in system. So let's start looking at systems and processes, not at the people. So thank you very much, Priyanka, and we look forward to seeing you all on 30th of July with Anita Krupa Jayakumar, when she will be discussing using quality improvement methods to improve care. Thank you so much, everyone, and we look forward to meeting you on 30th July, 11 a.m. to 12 p.m. Thank you very much. Thanks, Priyanka. Take care.
Hello, thank you very much. Very good presentation. It's a good now and then to remind for all the nursing leaders as well as it is enabled to teach the youngsters also in our continuing of our nursing activities. She has brought well about. So once again, I thank you. Well presentation.
Thank you, ma'am. Thank you so much. And I would also like to take this opportunity to thank Tangam ma'am. Ma'am's valuable inputs, guidance, and continuous backup has led this particular program to be the finest of it and be a great success. And we could present here so confidently is only because of her continuous guidance and being with us. And also for all the leaders who have given me this opportunity to be here, I thank them all with much obligation. Thank you all. Thank you, Durga,
Priyanka,
for helping me with the presentation.
You're welcome, dear.
Thank you, Durga, for stepping in an emergency, and thank you, Priyanka, and all the very best. And take care. Have a good weekend, all of you. Thank you very much. Bye bye.
Thank you, ma'am.